Welcome to the AOA News Inside Track podcast. Today's Inside Track podcast is part of the QIPS Insights series, which is brought to you by the Quality Improvement and Patient Safety Committee. We'll hear from leads of quality improvement and patient safety projects, exploring how they got started, what worked, and key lessons learned.
I'm Andrew Harris, Chair of the American Urological Association's Quality Improvement and Patient Safety Committee, here today with Dr. Zach Feuer, Assistant Professor of Urology at the University of North Carolina. Really excited to talk about the Quality Improvement Project on implementation of a telehealth-based program for the evaluation of men referred for elevated PSA, reducing time from referral to diagnosis. Dr. Feuer, welcome.
Thanks so much for having me. Really appreciate it, Dr. Harris.
And looking forward to this opportunity to discuss this very exciting work that you all have embarked on at the University of North Carolina. Can you tell me a little bit about the project, what it's about, and what inspired you to kind of go down this road?
Yeah, absolutely. So our project focuses on improving access and efficiency for men referred with an elevated PSA. We created a telehealth-based rapid access program, and that program was designed to sort of streamline evaluation, specifically from referral to biopsy, while reducing unnecessary travel and delays for patients along the way. I think as far as inspiration goes, most of the inspiration came from patient feedback directly. As a statewide referral center serving a state with a massive rural population, the second largest rural population in the United States, we consistently heard from patients about long wait times, the burden of multiple in-person visits. And so many of these men were traveling several hours for appointments that could have been completed virtually. And so we wanted to create a model that addressed those concerns directly, improving access and also maintaining the same sort of level of diagnostic quality and patient-centered care.
Yeah, I appreciate that. That's very interesting, going off of really what the patients want. I think you definitely have that opportunity in medicine more. A lot of times it's our schedule is 8 to 5 and they have to fit in it. And sometimes that's really challenging. So it sounds like you're really trying to address this rural footprint, drive time. How did you start to see there was an opportunity? Did you guys take a look at, and you already mentioned the rural footprint that you have, but your specific urologic populations, you look at your statewide population, and then why did you feel that it was important to go and address this issue?
Yeah. I think, generally speaking, again, patient feedback had identified the fact that there was extended wait periods. So we sort of looked back at our data to see how much time it was taking from the date of referral through sort of the date of biopsy. What did that look like in a pathway that's now fragmented with, a patient coming in to see us initially, then getting triaged and sent for an MRI. That MRI wait time adds to the process. And then after that, another wait for the biopsy. And so we looked at each sort of individual part of that process and noted that, of course, it was critically important because this was causing our patients anxiety, increasing the time that it was taking to actually get them cared for. And so when we examined our referral data, we found basically that from referral to biopsy was taking about 5 months in total time, and again, requiring multiple in-person visits, and clearly represented an opportunity for improvement.
I really appreciate your discussion. It sounds like you guys did a wonderful job really understanding current state and where you were starting. And so as you all understood that and you started to think about how are we going to approach reducing this kind of 5-month wait time, what kind of strategy did you use and what were your main goals? Was it, kind of increased access to care? Was it decreasing the MRI time, the biopsy time, or just all of the above?
Yeah, I mean, I think given that it's a pretty complex process, it has multiple different steps and stages to it. I think approaching it from a structured standpoint was important. So from a quality improvement lens, we sort of used the structured A3 quality improvement framework, which guided us through defining the problem, identifying some of the root causes, setting some measurable goals for ourselves, and iteratively testing changes. I think whenever you sort of approach a big problem like this that involves multiple different departments and multiple different staff members from various sort of backgrounds. The important part is mapping out the actual existing process, really understanding what is actually happening and engaging the stakeholders sort of early from every different component. So, we reached out to obviously our urology group, but, especially and importantly, our nursing staff, our front desk staff. In radiology, similarly, not only the radiologists themselves, but the techs, the front desk staff, to really understand that process and identify the bottlenecks and inefficiencies. Overarching aim was obviously to reduce the time to biopsy and minimize some of the unnecessary in-person visits along the way. And then, of course, we don't want that to compromise some sort of other outcome on the back end. And so our balancing measure here was trying to make sure that our diagnostic accuracy did not change with this process. And so I think that those were, some of the key components.
That sounds phenomenal. What a great example of really understanding not only what is the data-driven opportunity, but then also where are some of your efficiency opportunities lie, within the system, because we work in these complex systems. So really appreciate, this part of the discussion. So walk us through now, what you guys actually did. What was the intervention? Where did you start to make these changes to try to decrease that time?
Yeah, absolutely. I think some of the major bottlenecks that we identified were in appropriately sort of scheduling the patient initially. We didn't really have enough sort of new provider slots to get people in quickly. Of course, oncology, we covered the breadth of it. And so, those appointments were being taken up by a variety of different things, returns, et cetera. So sort of right sizing the number of incoming appointments was critically important. That virtual visit on the front end of things was actually carried out by one of our advanced practice providers with 15 plus years of experience and a passion for prostate cancer. And so he sort of became the point person for the entryway into the process, and that made sure that patients were coming in with a standardized approach. In terms of making sure that every patient sort of had the same experience, we standardized and developed a biopsy algorithm and an MRI triage algorithm. And upstream of all of this, in terms of making sure that patients were ready for their initial visits, ready for their biopsy, we ensured that some of the schedulers had algorithms for how to manage outside imaging, get that imaging so that it was accessible and reread and interpreted by our local radiologists. And similarly, having a nurse navigator sort of help them through the actual process in terms of the patients, getting them to the day of biopsy appropriately, ensuring that they had all the things that they needed, that they held anticoagulation, if there were any biopsy recommendations previously, things like antibiotics or enema completion, we made sure that all of those things were getting done so that we minimized cancellations.
That's phenomenal. So as you guys were going through this work, how were you tracking that data along the way? And did anything in particular kind of stand out to you, or what did you learn as you all were going through?
Yeah, so we monitored several metrics. Time. We sort of looked at we exploited each different part of this actual pathway. So we looked at time from referral to biopsy, time from referral to their actual first visit. We looked at time to MRI and how long it was taking patients to get in. Part of the critical thing was a capacity issue. So we realized that, by increasing our capacity, we could shorten our wait times. And so we completed some observational studies to get an understanding of how our biopsy day workflow looked, so we could increase the number of slots, and reoriented as well some of the, MRI spotting various different types of procedures outside of prostate to ensure that there was sort of again, those were right sized to match the number of patients that were requiring MRIs coming in.
As you were going through, any surprises along the way, or anything you didn't quite think about as you were learning until patients started going through the process that may have been a little bit surprising?
Yeah, I mean, I think, as the sort of end users in these kind of pathways, I think it's often easy to underestimate how complex these pathways really are. Obviously there's many, many handoffs along the way. Patients are going from a scheduler to a front desk staff to a nurse to radiology and their schedulers and our schedulers, and then coming back and making sure that the biopsy is in order. If there's outside imaging, getting that. And so when you actually map out the process in detail, you realize just how complex it is. And on the surface, it might seem straightforward to schedule an evaluation, an MRI, and a biopsy. But once you really see that, on paper, it really becomes clear that coordinating is kind of the critically important step in making sure that this happens appropriately.
Yeah, I appreciate those thoughts. One of the things that I love about quality improvement is the concept of you don't know what you don't know, right? Until you start down, you start mapping it out, and you start doing PSA cycles, and you just learn a tremendous amount along the way, which it sounds like you all did in this work. So what impact has the project had so far? If you could just go over kind of the results that you've seen as you all have been implementing this work.
Yeah, absolutely. I mean, we've seen a dramatic improvement in that sort of median time from referral to biopsy. Initially, we clocked in at a median of about 161 days, so just over 5 months. And now that process has been shortened to about 50 or 60 days. The current median is sitting at 55 days as of today. So pretty dramatic, significant improvement. We're down sort of, to less than half the amount of time that it was initially taking for us to get patients in. But then in addition to that, I think the patient experience has really been the part, the sort of comments and feedback from patients has been, wow, this process was so much easier. I only had to come in one single time on my biopsy day if they had already had their MRI previously. So it saved patients coming in from 2, 3, 4 hours away, significant amounts of time and cost. We looked at the data, and about a third of our patients were driving over 150 miles round trip to come see us, or more than 3 hours round trip to come see us. And of course, that's associated in these days with expensive gas costs and parking. That really quickly adds up, especially when there are multiple visits.
I really appreciate those comments. Listening to you talk through this, it sounds like the patient feedback led you to look at the data, then you move those metrics in the right direction, and you linked it back to new patient feedback and satisfaction. This phenomenal quality work in making sure your end result is linked to why you did it in the first place. So very much appreciate that from a quality lens. Have you all identified any other areas outside of this work where you might look to do something similar, or people have been reaching out to you and say, hey, how'd you do that? How do we do this in a different specialty outside of urology?
Yeah. So we have applied the same concept in, some other sort of pathologic states with the plan to sort of develop those further and expand this kind of rapid access concept. So we've already applied it to hematuria. So getting patients in quickly for cysto and evaluation through a similar sort of structured approach. And that's reduced patient wait times and again, improved their feedback. And we're planning to expand it out to patients coming in with renal stones and patients with BPH. Especially those who are sort of obstructed and with a catheter, trying to figure out how to get them through our system quickly to get those obstructions relieved.
Interesting. And as you move to the hematuria concept, was the work quicker the second time after you had already figured out the process you wanted to go through the first time?
Yeah, absolutely. I mean, I think, the good fortune with something like that is that we're working with a similar team and similar players overall. It was us in radiology. And so we already kind of had a structured approach and had already identified some of the ways to kind of make some of those wheels spin a little bit faster. And so I think, that was certainly easier the second time. I think we also get a little bit better at it. You learn a little bit from the first experience. You learn what works and what doesn't work. Sometimes we had a hiccup that delayed us a couple of weeks. And in the second go around, you're a little bit faster at kind of identifying, oh, this is going to be an issue. This is something that, maybe we should consider approaching a couple of different ways to, on the first go, rather than waiting for the first one to fail and see how that goes.
Yeah, I appreciate those thoughts. So what advice or resources would you share with others? You're going to listen to this work and say, you know what? I think I might want to do something similar. We may have a similar opportunity at our institution. What advice or resources might you share with those?
Yeah, absolutely. Collect the baseline data. Make sure you understand what the actual problem is. Make sure you measure it. Understand what you want to measure. And I think the critical thing is always to think through, there's a little bit of a game of whack-a-mole that comes about in quality improvement where, you allocate a lot of resources to a problem and then all of a sudden, the mole sort of springs up somewhere else because all of a sudden you're not paying attention. So I think, both thinking through what that baseline data looks like, understanding your process really, really well and mapping it out before you start actually trying to turn the knobs, if you will. But then I think, on the back end, just making sure that you understand where did you take those resources from and ensure that that kind of component of your practice is not suffering for it.
Yeah, I appreciate those concepts for sure. And that's just great advice for those out there looking to get involved and do something similar. So I really want to thank our audience today for listening. Dr. Feuer, thanks so much for spending some time with us today and really imparting on us some wonderful quality improvement knowledge. What a great work. Huge win for the patients and really just overall phenomenal use of quality improvement methodology. Thank you so much for spending some time with us today.
Thank you so much, Dr. Harris.
Thank you for listening to the podcast. Be on the lookout for new episodes from our QIPS Insight podcast series.
This has been QIPS Insights, an AUA News Inside Tracks podcast brought to you by the Quality Improvement and Patient Safety Committee. For more information about AUA's quality improvement and patient safety efforts, visit auanet.org/quality.